Good morning. So we are going to start our refractive session 3. I'm going to open this session. This session it will going to be a case presentations. So I think everyone will going to enjoy. We are going to start by Professor Cosimo Mazzotta. He's traveled in the early morning, but he put a very nice presentation. It's a pre-recorded presentation, and I hope everyone you're going to enjoy. We can start Cosimo presentation.
With a background of more than 25 years dedicated to R&D in ophthalmology, leads innovations in customized refractive surgery to maximize surgical performance. The 4D suite provides unmatched quality of vision, surgical invasiveness minimization, full process automation, cloud closed loop remote control. The 4D suite is composed of Precisio 2, the laser tomographer, P-Metrics, the dynamic pupillometer, Sipta 2, the web-based planning software, Iris 2, the fastest excimer laser, I-Verify, the cloud closed loop control application. The 4D suite unique multi-patent know-how supports the treatment of greatly, not alternatively amendable, invalidating corneal pathologies.
With this technology, we define an ideal shape of the cornea thanks to backward ray tracing technology, starting from the best focusing point on the fovea. A proprietary reverse retracing algorithm is applied to customize the ideal shape of the cornea, achieving a planar postoperative wavefront. The most important thing is that we don't need subjective refraction to define the ideal shape of the cornea, because all refractive surface being known. This was the patient diagnosed with an ectasia and that was implanted with a toric IOL with a not so good pre-op anchored distance visual acuity. This patient was not satisfied, so comes in our center for a visit and to do something to repair and to improve his visual acuity and the quality of visual acuity. We plan a customized profile of ablation determined as intersection between the anterior corner shape and the ideal shape, thanks to the Sipta 2 software that require the power and the data of the implanted IOL, a new biometry of the pseudophakic eye, and we don't need the subjective refraction, being all surface known. You can see here the input data. We have here the corner thickness, the anterior chamber depth, lens thickness, axial length from biometry. This is the power of the IOL, plus 1.25 sphere, plus 5.50 diopters, axis 145 degrees of the IOL. You can see here the preoperative anterior elevation map, the preoperative retracing anterior power map with the cylinder, the irregular cylinder, and the total power retracing that is less than the anterior because we take into account the contribution of the posterior surface, but also of corneal epithelium, but also of the lens, the IOL implanted. So it's possible to do a full ray tracing excimer laser correction given transepithelially to correct the residual refractive error in this pseudophakic eye with irregular ectatic cornea, because we know all the contribution, all the refractive contribution of the surface, anterior corneal surface, posterior corneal surface, and IOL power. You can see that we don't remove in full the cylinder, but we leave a small amount of cylinder to compensate the power of the IOL. This is the customized profile of ablation, and you can see that the novelty is that the applied refractive second order correction is automatically derived and measured according to the corneal anterior and posterior shape, the pseudophakic biometry, and the IOL data. In this way, we could do an ideal shape taking care of the posterior cornea and the IOL refractive contributions. You can see here the preoperative maps, the anterior elevation map, the ray tracing anterior power map, and the total corneal ray tracing map. And you can see here the postoperative ray tracing anterior power map and the total corneal ray tracing map, where you can see that we leave a small amount of cylinder compensating and neutralizing the IOL cylinder. So this patient passed from 2050 to 2022, uncorrected distance visual acuity. Cornea first, so, but also cornea after, thanks to
Can we press again? No, it didn't finish. No. Ended? No. There is another video. Okay. Dr. Muhammad, what do you think about this technology? This is very important to comment.
I'm a very big fan of this technology. Actually, this has been a refractive surgery dream over the past like 20 years. It has been promised by one of the very famous platforms, i.e. Wavelight, Alcon Wavelight. It was supposed to be in the pipeline. There was coming, there was an ablation profile called Innovice that was going to be released just before the COVID era. And I think that the project stopped for some reason, but the ultimate ablation profile has always been sought after, and the ultimate ablation profile proved not to be the topography guided treatment nor the wavefront guided treatment, but the ray tracing guiding treatment. And up to this very moment, for some bizarre reason that I do not understand, no efficient ray tracer has been affiliated and connected to an excimer laser platform. Now, this is an oldish company, the IVIS, that has been renovated and has been had a facelift by Cosimo and his colleagues. And what he showed right now was the ablation profile being applied on an irregular cornea, which is the real challenge for any refractive surgeon. So if you can have this pretty good results in an aberrated cornea, this means that your ray tracer works, and much more than that, because a lot of ray tracers do work. But what is more important is that how can you translate the very complex design of this ablation on the right position on the cornea. So this needs a lot of technology in registration, how to put exactly the profile in its place on the cornea. And in order to test this experiment, you will need the results. And he is reporting very good results in this last case where the patient had the best corrected visual acuity of 20/50. It went up, it shooted up to 20/22. So this is really, really impressive work by Cosimo. I'm pretty sure I was just telling Dr. Yahya, my mentor and professor, that I think with a few presentations like this from Cosimo Mazzotta along the next few meetings, this platform will be acquired by a giant company, and I think this is the future of refractive surgery. The thing that Cosimo did not mention, though I would have loved to pick his mind on this subject, is will we have the ability to choose what to treat and what not to treat, because these are very sensitive corneas with irregular patterns and thin pachymetries. So we really need to, to be tiptoeing while we are ablating this stromal tissue. So will we be able to choose what to treat and what not to treat or not? I would have loved to have this conversation with Cosimo, but unfortunately he's not here.
So the dream started to become true by this ray technology. I think also there will be a distributor, I think, in the already in the Middle East for iris, already finalized. IVIS, yes, already signed, and maybe soon in Egypt also we may have the machine also. No. By the distributor, I think it will be in the Middle East, and it will cover all the Gulf area. I think so. So the next presentation, definitely by Professor Hosni. He's going to present definitely a very nice case, as usual. So let's listen and see what Dr. Mohammed Hosni is going to present.
Okay, good afternoon, everyone. Shall I use this or that? No, okay. I thought I was the third up, but someone did not show up. So my case today is an epithelial ingrowth case. I have presented this case before. Epithelial ingrowth is a feared complication of lamellar refractive surgery. It's more prevalent in patients that suffer epithelial sloughing during the procedure, patients that underwent flap repositioning post-operatively the second day or the third day, patients undergoing redo touch-up procedures. It's less prevalent in patients who undergo femto laser-assisted LASIK due to the firm sealed attachment of the flap edge, the inverted side cut, if you're using an inverted side cut of the flap edge, the exact flap bed fit, the perfect fit, and the lower incidence of post-operative flap dislocations or striae necessitating intervention 1 day or 2 days after the surgery. So this is my case. It's a 31-year-old male. He underwent LASIK 2.5 years ago, reporting rough surgery in the right eye. He was sent to the OR for repositioning on the second day. 6 months later, had a gradual decrease in vision in the same eye that had the trouble during the surgery, went to his ophthalmologist who diagnosed epithelial ingrowth and recommended flap lift, did a flap lift and irrigation. Everything was absolutely fantastic for another 6 months. Then the patient started to experience blur in the same eye. Went to another ophthalmologist who diagnosed recurrent epithelial ingrowth and took slit lamp photos for documentation. His new ophthalmologist recommended flap relift, removal of the epithelium, mitomycin C, and flap suturing. So everything, all that we have in our armamentarium. And the procedure was performed and suture removed 3 weeks later. Patient reported improvement, but vision never fully recovered. These were the pictures preoperatively before the second intervention, and I think his ophthalmologist took these pictures for medical-legal purposes and gave it to his patient. 6 months after the procedure, he began to experience gradual deterioration of vision of the right eye vision, along with increasing photophobia. At the time, he was abroad on a drilling job. He's a petroleum engineer. He was locked down during the COVID times for 2 months on lubricant self-medication before being able to fly back home to Egypt. He decided to seek another ophthalmologist's opinion, and this was myself. On presentation, on examination, he could not open his right eye due to severe photophobia. I could barely examine him, only with dim light, even after topical anesthesia. The patient was squeezing his eyes forcibly for the fear of photophobia. I really felt sorry for the previous two surgeons, especially his first doctor that did the primary LASIK. He had lower flap melting, recurrent epithelial ingrowth, and his morale was severely affected. The picture, I'm not sure if it is very clear or not. He had lower flap melting and epithelial ingrowth. Not as severe as the second time, but definitely severe enough to deteriorate his vision. So I decided to do a flap amputation since everything else was previously done, and this was, I think this is a landmark study that showed that suturing post-LASIK epithelial ingrowth has really little impact in contrast to our current knowledge. So can you play the video, please? Yeah. So this is basically what happened. The flap was molten. It melted in the lower part, and there was a lot of epithelial ingrowth. I decided to amputate this flap. Nothing fancy there, just to show the procedure. Again, a lot of this irregularities that you can see is nests of epithelium causing pits and melting in the stroma of the bed. I really had to clean a lot because there was a lot of hidden epithelial nests on the apparent bare stroma. You see, the more you scrap the cornea, the more epithelium came out. It was a real mess. It's just a very short video. And the lower part of the stroma was molten. This was a full thickness epithelium that had to be removed as well. Left the patient with no epithelium at all. With a bare stroma. The lower part had the epithelium. It was an over-exaggerated thickness of the epithelium in the lower part because there was no stroma there, was melting. And that was pretty much what we did. Put some betadine eye drops and contact lenses. And that's that. Okay. Now the stroma started to look a little bit regular, like the stroma that we usually see in LASIK procedures. And by stroma, I mean the bed. Unfortunately, yeah, betadine eye drops and contact lens.
A question during this photo.
Yeah.
If there is any role for PTK to remove this epithelium or no?
Yes. The problem, Ashraf, was many folds. The first thing is that this is a patient that we will amputate the flap in, so you'll end up with a really thin cornea. Not really thin cornea, but we're talking about 300s. So I wouldn't prefer doing any PTK more than this. This is number one. Number two, if you're going to do a PTK, you will need to have a coupling agent that has the same ablation threshold as the corneal stroma. And we do have this, and we can actually use the epithelium itself that's in the gutter as a coupling agent. But I didn't want to be over-philosophical in this type of patient, and I want to do something which is straightforward and really appraise the results. So the post-operative course was really good, much better than I expected. This is 3 months post-operative, 6 months post-operative. At 9 months, he had an uncorrected visual acuity of 6.9. The best corrected visual acuity was nearly 6.6. He had 0.75 diopters of astigmatism. He didn't have photophobia, and surprisingly, this was the very important point on his side. He really could open his eyes, and he told me that he's really having his life back. Patient satisfied after a stormy 3-year period of suffering. So basically, the flap amputation for severe epithelial ingrowth, in severe cases of epithelial ingrowth, epithelial nests can lead to stromal melting above and below the inoculated epithelium. This can lead to serious flap melts and susceptibility to infections, along with irreparable visual loss. In cases where epithelial ingrowth is severe, flap amputation has been proposed and success has been reported repeatedly in the literature. Again, there are many studies. I do trust very much George Quinones. And so he has a series of publications. Part of them has been done in Switzerland. He's a professor in Lausanne, and he actually works in Greece, and he was affiliated to the US, so he has multiple practices. And he had publications when he was in Switzerland and with combined work with Sonia Yu. So I think that's that. In conclusion, epithelial ingrowth has been can be extremely annoying for patients. Not only does it affect vision, it can also cause photophobia and flap melting. Removal of the epithelial nests and application of mitomycin C can work in moderate cases, but the value of flap suturing is debatable. In extreme cases, flap amputation is a valid solution and yields excellent results. Thank you so much.
Amazing results, amazing results, really. This is amazing. But from your experience, why the corneal melt happened?
It has been reported epithelial ingrowth, the epithelium itself secretes proteolytic enzymes that actually melts the corneal stroma of the flap over the epithelial nests. Now, in this specific case, Ashraf, he's a very nice person, but he has been for 3 years, almost 3 years, closing his eye like this. I mean, and he as well told me, I don't care at all if I'm wearing glasses again, I just want to open my eye. And he cannot open his eye to watch TV at night at home. So it was really bothering him. So the wow effect came from the photophobia that went away. And surprisingly, he ended up with a 0.75 diopters of cylinder, which he's over the moon. He's very, very happy, and me too.
And this wonderful technique, when you decide to do it in any cases, what cases that we can do amputation of the flap?
Okay, now having presented this case, this is actually the only case in my 25 years of doing LASIK that I did a flap amputation for an epithelial ingrowth. I was, of course, the only thing that made me take this decision, of course, the publications. And when you read publications, sometimes the publication sounds very, very nice. It's very well written, but you have to take a look at the authors. And George Quinones is a really, really credible person, and I admire him and respect his experience. The other thing is the patient reported he's a very well-educated person, and he reported that the previous ophthalmologist did a great job. One of them did everything that I would have thought of. He put back the flap, sutured the flap, and took out the sutures after 3 weeks, which means that he knows what he's doing. And even so, after this good management, we didn't gain much. So I thought this was, if anyone in my career that I would do a flap amputation for, it would be this patient. And I did it, and fortunately, well, everything went fine.
In some cases, you can remove the flap and do anterior lamellar keratoplasty, about 200 microns in the cornea, flapless without sutures, anything. Do you do this with the flap?
Yeah, but we do this, but yes, for a totally different indications. In herpetic and anterior herpetic scars and stuff like that, we do a femtolaser-assisted anterior lamellar keratoplasty sutureless. Yes. We've done this before, yes, but this is something else. Yeah, I didn't want to do this.
You cannot. Yeah,
I didn't want to put another cornea, donor cornea, on top of this bed and then wonder why does the patient does not see? Is it? Yeah.
Thank you so much.
No worries.
There is a question.
Sandeep, yeah, of course.
What is the role of using scrapers dipped in alcohol to remove epithelial ingrowth? Do you
Yeah.
think that's anyway is going to have any impact?
Yeah, yes, you can do this, but for patients not like this, this was like an end stage sort of epithelial ingrowth. And from what he reported, the other doctors, of course, when you get a report or you get a resume of the case from the patient, some details will be missing because he's not an ophthalmologist. So maybe one of the doctors used alcohol in his approach. He told me that he was told that they used MMC. And he had these sutures put and removed after 3 weeks. So the person that did the management before this patient came to me really did his job. And this was something challenging for myself because I had nothing more to offer. So I just searched I scrapped the barrel basically to see if there's anything else that we can do for this patient before telling him you will be needing a corneal transplant. Okay, and I found the repeated reports by Quinones regarding flap amputation. And honestly, after I did this case, I'm a little bit afraid that the threshold for my decision to amputate flaps will be much lower. So I will be the flap amputator from now on. So the thing is, this patient ended up seeing 6/6 unaided. So that's that.
Excellent case, Dr. Muhammad. But I think the message also that we can convey that epithelial ingrowth can be disturbing and serious. Oh. So we have to be very careful in the redos and yes. How we manipulate the flap, making sure, trying as much as possible not to induce epithelial cells. So epithelial ingrowth can be really, thank you very much for this excellent presentation.
Is Dr. Ahmed Ghunaim is here? No. Okay. So we are going to the next presentation by Dr. Muhammad Ahmed. He's going to give a very nice presentation, I think so, as usual, Muhammad.
Thank you, Dr. Ashraf. First slide, please. I would present a case today who came to me at 2016, a few years ago, and I have an extended record of following up this case. This 31-year-old female visited the hospital in November 2016, came for blurred vision in both eyes with after refractive correction. She had a smile procedure in Egypt at October 2016 with some difficulties. She mentioned that there is some tough problem happened, especially in the right eye. And her previous refraction was minus 2.50. Her best-corrected vision was 612 in the right eye, 618 in the left eye. Pressure is normal. The refraction is minor, which is not explaining this loss of vision, plus quarter diopter with minus half cylinder, almost in both eyes. And the slit lamp in the right eye have some findings. There was superior temporal corneal opacity between 10 and 11 o'clock with extended opening wound about 2 millimeters. This is for me, meaning that the surgeon has faced some problem during the extraction of the lenticule. And I can imagine that there was some extra manipulation in this eye. While the other eye was quite normal, clear cornea, normal vertical wound, no opacity at all. Of course, fundoscopy and posterior pool was within normal limits. So if we look, that was the first topography I did when the case came. You can find out that this is typical after surgical correction. The anterior surface looks, of course, a little bit elevated, but the posterior looks normal. This is the other eye. So there is elevation in the anterior, but not in the posterior, just a mild suspicion. This is also another photo. So the discussion, why the patient is not seeing? Why the vision is not as good as it should be? Is it a DLK? But obviously there is no signs of cells or deposits or sand of Sahara or whatever there. So for sure it is not a DLK. Is it a decentration or irregular cornea? There is some coma and high order operation, but it is not explained this amount low vision. Is it ectasia? Well, still always in the back of our minds in any laser vision correction. We suspected the ectasia, but in order to confirm that, we need the pre-op data. We need to know how this cornea was before. So we asked the patient to kindly bring for us that pre-op, and that was the pre-op. If you can see, we can see some suspicious elevation in the anterior surface, slightly in the posterior surface, but in general, the thickness is acceptable, and if we look, this is all what we can get. It is a suspicious case. I would say a borderline case, and this is the other eye as well. So, in my opinion, this pre-op suggested some kind of form of frost, or at least borderline cornea. So there is a possibility of ectasia, for sure. We will keep it in mind, and we will put it as in our pack. So decision was made to continue the conservative treatment on lubricant and steroids and monitor closely. After 10 weeks, after 2.5 months, the vision improved slightly, but with pinhole, it reached 6.9. That was a good sign. The scare area settled down, of course, with the steroids. The edema resolved, for sure. And if we look to the topography, it is not so much changed. It's almost not that much changed, to be honest. And if we look, we still does not have a clear signs of ectasia in this case. This is the 10 weeks after the medical management. If we look to that comparison, we can see that the thickness has slightly decreased from 456 to 431, but the keratometry is the same. So that encouraged me to discuss the possibility of pros and cons of cross-syncing in this case with the patient, especially that cross-syncing, the possible haze, the possible decrease in vision. But the decision was to wait for another few weeks and monitor before going for CXL. After 2 weeks, patients surprisingly start to report improvement in vision. Her vision becomes 6.9 unaided and 6.6 on pinhole. Topography shows improves in the corneal thickness. And explanation, to be honest, I don't have any real proof why this happened in this case. I assume that this phenomena is related to keratocytes activity. But unfortunately, we don't have any confocal microscopy around to show or to prove that the keratocytes was activated in this case. Do you have, for the other colleagues, Professor Hosni, Dr. Ashraf, any other explanation?
Yeah, can we return to the photos again, pre and post? Because there is much improvement in the anterior curvature in the right eye compared to the previous, after the treatment.
This is the pre.
The before, yes, before treatment, you saw you give a very nice picture.
This is the pre-op.
No, before you when you saw the case, you did a pentacam.
Yes.
Before this, yes, yes, and the right eye. Yes. See, there is in the right eye it was a elevation map in the right eye. Yes. After the treatment, and it's it's around +8. And after the treatment, it becomes improvement. And the left it was like this +11. And see, after your treatment also, it was much improved in the anterior elevation.
Exactly.
Yeah.
This is what's explained, as I understand, because of the edema. There was some edema,
yes,
and haziness in the cornea in the first, when the patient first shown up.
Yeah, we can say it is an edema definitely, and some ocular surface disease that was managed properly by the treatment, because there is no signs of ectasia, because the posterior elevation didn't change before the operation or even the first, when you saw the patient, and even after the treatment?
Exactly. That's why I was not keen to do or to rush up to corneal cross-linking, because I was not convinced that this is an ectasia case. But I was trying to find out why this drop of vision is there, although the residual refraction is almost negligible. So I'm just trying. That was the early days of SMILE, to be honest, at least for me, and I think even in other countries. My explanation for that, I would just assume a theory. Of course, this is after 6-week follow-up. My theory was, in some patients, the energy we are using during creating the flap and the manipulation might cause some keratocytes activation. These activated keratocytes is not activated severe enough to produce a haze, but it's still bright. And later on, I've come across some studies published, I think by Professor Dua, showing under corneal confocal microscope that this activated keratocyte looks a little bit shiny, and it causes more diffraction of the light during the stroma. Although we are not seeing the haze, we are not seeing a real significant morphological change in the cornea, but it does has an effect on the end result. And it takes some time to settle down, and the vision will recover later on. So to conclude in this case, I do believe that wait and given time with careful monitoring sometimes might be a good option for the patient and avoid the surgeon some complication. And at that time, I would say SMILE is still have a lot of things which we are not fully aware about it. Of course, we are still learning, and we are looking for the perfect procedure, which is to come yet at one day. Thank you very much.
Thank you very much. Very interesting. But I would add that, as Dr. Ashraf said, the ocular surface treatment is very important to judge any topographic findings. And also, did you say how much? You said the cornea thickness improved. How much did it improve?
It's improved. I think it was from, the number is there, but it's around 15 micron. It is 15 micron. 15. So that's not a big difference because the vision is improved from 618 to 69 and aided and 66 aided. So I think that the topography has, of course, improved, helped a lot, but there is something in the cellular level. This is the real improvement which was achieved in this case.
But you didn't measure the epithelium, for example.
Sorry?
There was no epithelial hyperplasia.
Well, unfortunately, I don't have the epithelial mapping at that time, so that's why.
I know that you do a lot of SMILE. I know this. And you know that Zeiss, when you said this, the machine, you said the energy.
Yes.
And it's different from one place to another. If the edema that happened during the dissection, definitely I think we can say that it was not proper, the energy was created, maybe it was not proper, so he took a lot of time to dissect, because you know that if we decrease the energy, the dissection will be difficult. If we increase the energy, the OPL will going to be a lot in the operation. So I think it's also a machine setting to create the proper energy setting for, especially for Zeiss machines, that it needs from one place to another different settings.
Exactly, Dr. Ashraf, and I was guessing so because of the severe manipulation. When you have the initial wound extended, that means the surgeon has suffered to extract that lenticule. That's why I assumed that there was a lot of manipulation and there is a problem in the power.
Thank you so much.
Thank you.
And now we are going to have Professor Dr. Yahya Salah from Cairo, Egypt. He long-term experience in cornea cataract refractive surgery, and definitely he will give amazing case as a case presentation.
صباح الخير. I want to share with you another type of surgery. We should not think of refractive surgery as only laser vision correction. There are other options. There are non-laser refractive surgery that includes phakic intraocular lenses and refractive lens exchange. So I'm a fan of ICL. I've been using it for a long time. And it's a very good thing that you have, as a refractive surgeon, in your armamentarium, different options for the patient. Sometimes people squeeze the indication for laser refractive surgery, and this is why we can get more complications like ectasia or bad quality of vision, because we squeeze the indication. I have done ICL for cases as low as -3, -2.5. So it's not only limited for high errors of refraction, so you should have it in your armamentarium and use it in the proper side. In spite of that, you can still, if you neglect one of the rules, if you're not attentive, even if you are experienced, you can get into problems. Can you, do I have here? Oh, okay. So this is a 60-year-old nice young lady that was operated actually less than a month. This was her second eye doing ICL. She was in the range of -6. She came in the first days, the fellow in the first follow-up, the assistant just told her it's normal, you're not seeing, the refraction was not good, but actually when I saw her, and the refraction was +6 sphere and 2.5 cylinder, and she was myope, and her first eye was perfect, and she was on target. So you have to stop and think what could make this for this patient. And she was a really nice patient. She was not aggressive. She was asking just why this eye I'm not seeing well. So I have to sit and examine her properly and try to understand what is the problem so I can help her. If you look here, if you examine her on the slit lamp, and if you see here, you will see that the lens is centered well. There is some peripheral anterior synec. The iris in certain parts is close to the angle of the anterior chamber. The pressure, intraocular pressure was okay, was good. So I just try to, if you can help me now, think what could do this. Everyone thinks what could do this. So you can clinically try to identify the cause, and then you can ask which investigation should I do to confirm the diagnosis. Then you take a decision to treat the patient. So you can see, have anyone have idea what could this be, why the refraction is like this?
Yes, I can say. I can detect maybe the haptics.
Not you, I'm asking them. So it's a challenge that you are going to, at one day of your life, either you will be the cause, or this patient will be referred to you and you have to answer. So from the clinical appearance, I started, although I have talked about it so many times, teaching how to do ICL, but I made the mistake myself that I would imagine, because of the peripheral anterior synechia in two parts, I guessed this ICL must be flipped upside down, and we know we have a curve, and this is the reason why the refraction is completely changed, and there is the cylinder there. It was not that dark for me, but so it's an upside IOL. So I told the patient we need to adjust the lens. Now I know the cause. I did her Scheimpflug image and anterior segment OCT that clearly demonstrated that the lens is upside down, as you can see here. So the decision to admit the patient to the OR and be very careful, because you are operating again on a clear lens, so you have to protect the cornea, you have to protect the lens, and you have to adjust the ICL. The beauty of the ICL, the star one, is the material. It is very flexible. So here I'm injecting from the hole viscoelastic to elevate the lens and give a space under the ICL in front of the crystalline lens, and then bimanually I'm trying to flip the lens, keeping in mind I don't want to hit the cornea, and I don't want to enlarge the incision or even to go and get the lens outside of the eye, because if you get it outside, it's very easy to extract it. Yes, you can do this is one option, but still you will have a little bit increased risk of infection because you've got the lens out, it might be contaminated. So I was trying my best to flip the lens inside the eye, and all the time, because this is not a day-to-day practice, you start to think how I'm going to flip it mechanically, how I'm going to use the cannula and the iris repositor to flip it. And preferably, you should inject also a visco-adhesive on the anterior chamber to protect the corneal endothelium, to have a film protecting the corneal endothelium. All the maneuvers are carefully made, and you have always to make sure that you are aware of the position of the lens and the anterior capsule and aware of the cornea. So you are working and thinking in all different dimensions. Once I am able to get the lens in the anterior chamber, I was thinking I could flip it behind the iris. It was not easy. So now you can see one is زي اللي بيعملوا فطير كده. You are one hand is flipping the lens, and it is very malleable. Remember, there is the IPCL, which is the Indian type. It's made of a different material. You cannot do this. Just a warning. In an IPCL, you have to get it out. With this polymer material, you can do this flipping inside of the eye. Carefully, and the idea, as we all know, you have to have the hole in the haptic, the leading hole to be on the right side, and the trailing hole to be in the left, to make sure that the lens is in the proper position. Also, take care that in the IPCL, the Indian type, this type, the holes are in the opposite place. So it's in the left for the leading and on the right for the trailing. Once it's flipped, now it is as if I'm doing it primarily, as a primary surgery. I'm getting the haptics You see, this is the hole in the haptic in the right position. The trailing is in the left side and the leading on the right side. And you flex the haptic into behind the iris. Once the iris starts to constrict, this flexion is not easy, but again, you have to be careful. Once this is done, you make sure that the lens is properly centered. You remove the viscoelastic, either by irrigation aspiration or by displacement, just to avoid an early post-operative rise of intraocular pressure. And here, I'm dissecting by the visco cannula, the synechia that formed. And remember, these are very lightly attached in the periphery. Peripheral anterior synechia, so you do synecholysis, viscosynecholysis, to prevent later on zipping of the angle of the anterior chamber and to avoid increase in intraocular pressure. See, where the areas of the peripheral anterior synechia, you just dissect it, and it's very easy. Just be careful not to be too violent because you can get bleeding. And the longer the synechia is present, the higher the risk that you can get bleeding. But this will not prevent you from dissecting or doing goniosynecholysis. So this is the case I wanted to share with you, and thank you for your attention.
Dr. Yahya, it's not an easy to flip an ICL inside the eye. He's an expert surgeon, so it's not an easy because you should protect the cornea and protect the lens. And you are working bimanually in a very closed airspace. This is very, but from where you can see that the ICL is flipped or not from the reflection, this is why the reflection of the optic when you show the first picture, because it is not like this, it is like this. So there is a reflection circular, means that the ICL is flipped down.
But it's not that easy if you don't think of the option.
Yes.
And sometimes you can do the same maneuver. Strangely enough, after this case, like 2-3 weeks later, and one of my colleagues was working next room to me, and I've shown this case for them. So he told me, please come, I have injected the lens upside down. So he identified intraoperative. So we did the same maneuver, but we identified intraoperative. So you can use the same thing if you identify it. Don't wait and say, we will see what happens. If you identify a problem, solve it on the spot.
And the message, when you inject the ICL, before you tuck it under the iris, look for the hole. If it's not to the right side, it's wrong. You should flip it.
I would recommend earlier recognition. There are 2 points that you should recognize. When you are loading the lens, make sure you are having it in the right orientation. But sometimes when you inject the lens, it rotates the opposite side, even if you orient it properly. The trick here is that we should think differently than the way we inject an intraocular lens in a phakic patient. We are used to inject rapidly the intraocular lens because it passes very fast and folds very fast. In the ICL, to make sure that you are folding it in the proper position, when you inject slowly, and you will see the first part of the lens unfolding. You will see where is the hole, your eye on the hole, and while injecting, retrieve your hand to the outside to give a space for the lens to unfold. Sometimes you'll see it unfolding in the wrong way, so you can rotate your hand to make it fold in the right way. So it's better to see it and correct it even before it happens.
And another trick I'm always doing during the injection with the paracentesis, I put the second during the injection over the lens during unfolding to make sure that the lens does not always till I'm sure that it's folding completely, then I remove my hand. Usually I protect to be flipped. So I think we come to the end of our session. Any question from the audience? We present a lot of cases. Okay. Thank you so much. Thank you, Dr. Yahya, for sharing this. Thank you so much.